I always wanted to be a doctor from when I was in fourth grade. So it was a dream of mine. I read a book about Elizabeth Blackwell, the first woman doctor, and I wanted to do what she did. And no one else in my family is a doctor, so I don't think I really understood what doctors do, but I had a vague idea that they help people. So I had planned on going into internal medicine. And then when I hit the wards, kind of really started seeing patients as a third year medical student, I was very surprised. Like, is this what it is? And one of my first rotations was in primary care. It was in outpatient internal medicine, outpatient sort of primary care internal medicine practice. In terms of what you're asking me in terms of my approach to a patient, I think when we think about our thinking, which is called metacognition, we're going to do things a little differently, maybe, than what we do. But I think actually a lot of us as doctors already do this. But when I started learning about metacognition, it really gave me language as to what I do. So that I think has been sort of transformative. And what I mean by that is Daniel Kahneman has a book called Thinking Fast and Slow. And other people have written about this type of metacognition, but his book is a bestseller, and he won the Nobel Prize, and it really encapsulates it. And he terms it system 1 and system 2 thinking. Other psychologists have called it type 1 and type 2 thinking, but it's fast, slow. And what's fascinating is that experts think fast, and they need to think fast. So that's very important type of thinking. I recently read, though, that fast thinking is almost like hardly thinking. And in some ways that's true. I can look at something on the patient or under the microscope, and it's like almost instantaneous. I know what it is. And in that sense, it's hardly thinking. It's the same thing as when you drive somewhere you're familiar with and you're distracted kind of with thoughts in your head, and you get there fine. But if someone said, oh, did you see this or that? Or do you remember, what happened like right at that corner? And you're like, oh, I didn't really see any of that. So that's also, the active driving is system 1. And then the person next to you who noticed all this stuff, maybe that's more system 2 that you just, weren't even thinking about. So my approach to the patient now is to hopefully have that fast, initial, quick gestalt of what the patient has. For dermatology, that's largely visual, but information from the patient can be very important. And so to also listen, hopefully fast, right? To be able to draw that information from the patient quickly, but also to have a slow component of that listening, to be able to sort of ask open-ended questions and to pause and to give the patient that space to answer. I realized that I wasn't good at that. And so I think that part of my approach has changed. So see fast and, hear fast, sort of observe fast, listen fast, but then there's also a slow component. And so the slow component to visual recognition is when something doesn't immediately come up right away. And that still happens to me. And it makes experts uncomfortable to a certain degree. And that's another way my approach has changed. I've learned to feel more comfortable with that, comfortable with not knowing. I do believe that dermatology, which also, so visual, has tons of science behind it as well. And to be a good doctor, you do need to know that. And that's hours and hours of work and countless amounts of studying and all of that. And I know that, so there's this battle between, well, there's that knowledge, which is science, and then how can you waste time almost on this sort of like emotions and feelings? And I would say, yeah. So what's lovely to me is that you just need to be aware. Just be aware. And that's the system 1. There is emotion underlying this interaction. There always is, especially most critically when the patient himself or herself or themselves is anxious or worried or stressed or upset about something. That emotion for the patient is going to overshadow in some way the entire interaction. And if that's not somehow acknowledged, the interaction just doesn't go as well. And I've experienced that as a patient, as the mother of a patient, and as a doctor. And so I think there needs to be that awareness. A lot of my research has been on squamous cell carcinoma and keratoacanthoma. I'm fascinated by keratoacanthoma because this is a tumor, that name, the language for that tumor came out in the 1950s in England. And the way that this was defined early on, I think still holds true today. It was defined as a tumor, a mass, something that's growing rapidly on the patient. The patient will notice it and often will be like, what is this growing on me? It grows that fast, and then goes away. And typically it goes away within a month, but it can be longer, 6 months, even to a year has been described. So that's a keratoacanthoma. By definition, and I agree with that definition, it needs to be something that grows rapidly. When it's growing rapidly, it mimics squamous cell carcinoma, and that was in the earliest definition, and then it goes away. So whenever I'm asked, how do you tell the difference between squamous cell carcinoma and keratoacanthoma? I'm like, well, you just need to see if it goes away or not. And that's really the answer. The problem is that in the US now, we often don't wait for things to go away. And I'm not sure why we do that. Patients do need to wait for surgery oftentimes here, at least a couple weeks, if not, sometimes 2 months. So it's not like we don't have time to wait for even a month for a lesion to go away or start to seem like it's going away. But I think it's maybe the way that medicine has shifted. It's a symptom of it, that we're fixers. I heard yesterday too that doctors are fixers, and I would agree with that. I'm thinking a patient comes in, they have a tumor. Oh, I know what to do. I biopsy it. It's cancer. I send them to have it cut out most of the time in the US. But there was a really beautiful study out of Brazil where they looked at tumors that they thought clinically would be keratoacanthoma, meaning something that would go away. They did a partial biopsy of 25% of the lesion, and then they followed it. And they said the majority of the time they were correct. And at follow-up, a month later, that tumor would be shrinking, would be going away. And then that was a true keratoacanthoma. So they had the same definition as me. Any tumor that wasn't shrinking, they classified as squamous cell carcinoma. And no matter what, squamous cell carcinomas they would treat for the most part. It's Brazil, it's a different kind of medical care system. The ones that were going away, they would watch. And the ones that were going away, at least partially at a month, would completely go away the rest of the way. Maybe can tell clinically. I do still recommend a biopsy. And then I can't tell if something's going to be a keratoacanthoma for sure. So I will admit, I rarely use the term keratoacanthoma in a report that I am signing out as a dermatopathologist. I do think that's up to the clinician because you can't tell at one time point. It depends on the ultimate biologic behavior. But I will sometimes have, C notes, and have a note in my report saying, and I'll mention keratoacanthoma. This could be a keratoacanthoma, especially if the clinician mentions it. And then hopefully they will take that information. And I know some clinicians that I know do take that information, and they will give that tumor a chance to start to go away, especially in a particular patient who they talk to and they don't want some kind of, surgery. They'll watch it. And so that, I think, to me is a good approach to squamous cell carcinoma versus keratoacanthoma. I think it's really well done. It actually, and this is a classic sort of example of rethinking. Another book I love is Adam Grant has a new book called Think Again. And so that's also about sort of system one, like our initial thought is a system one thing, and then to rethink it takes system two thinking. During COVID, right, there's been so much of fast thinking and slow thinking, and every country, fast thinking is different and slow thinking is really different sometimes. In the US, state by state, city by city, sometimes, on an individual level, on a school level, on a government level, the fast and slow thinking patterns are quite different. So initially, I had written a paper where we found a signal for immunohistochemical signal. So that's an antibody that will latch onto a protein if it's there. And hopefully it's very specific. An antibody that recognizes spike protein. And spike protein is the little dots along the outside of the virus. I'm sure everyone has seen photos of that. And so that antibody is supposed to just recognize spike protein alone and not anything else, ideally, in an ideal world. So we stained some lesions of so-called COVID toes, which also are known as, COVID-associated perniosis or perniotic lesions during COVID-19. And that's what, the paper in JAMA Derm is about, those specific COVID toes or perniotic lesions, and whether there's really virus in it or not. So my prior work, we had stained for spike protein, and we had found a spike protein signal in the endothelial cells, in the vessels of, COVID toe-like lesions or COVID finger-like lesions. And so we thought, that doesn't mean that full-on virus, like intact virus is there, but it seemed like there's a signal for the virus. And so that somehow the virus is directly related, even if it's just via the spike protein deposition, but the virus is directly related to causing these COVID toes, these perniotic lesions. Anyway, so then that JAMA Dermatology paper comes out, and they did actual PCR, right, polymerase chain reaction testing for virus, and it's negative in all of their cases. So I think that's really telling, right, that there isn't, PCR is so sensitive. And also subsequent to my first paper, I had also rethought it, because we then developed, we validated, we didn't develop the RNA in situ ourselves, but validated and RNA in situ testing on skin, in skin for RNA of spike protein. So then we looked at whether there's actual RNA of spike there, and there wasn't. So we concluded from that even though the spike protein antibodies bind me, either it's really spike protein that's disassociated from the virus and floated through the bloodstream and deposited in the endothelial cells and caused this skin lesion, or it's a false positive, completely false positive, or it's that spike protein antibody is actually recognizing some other protein that's perhaps very similar to spike protein. It's just not a specific signal, but there's no RNA there. So there's no active viral replication going on there. So we had seen that already in tissue. And so I do really, I'm a firm believer that the findings in that JAMA Dermatology paper are true, and there's not active virus that's replicating in the skin lesions. It kind of doesn't make sense, because if there were, it would be, I think, illogical, sort of not a logical thing, because the majority of those patients never had COVID, at least as far as we can tell. Some of them have been exposed, but they're still asymptomatic. And so to have enough of a viral load somewhere that, and you couldn't detect exposure or an infection in them, and somehow that intact virus is replicating in your body and travels to your fingertips or toes especially, and creates a skin lesion, and then the virus is continuing to replicate there. When you think about it that way, sort of slow thinking, it's like, yeah, I don't think that really happens. Of course, we know certain viruses do have tropism to the skin, wart virus, of course, right? But that's usually direct contact. You touch something that has virus, maybe you have a cut, or, and somehow then there's enough replication locally. Herpes viruses, same thing, right? Chickenpox, direct contact, you get a lesion. There is, of course, herpes zoster, where the virus is dormant then in your nerves and then travels through nerves out to the skin, and you get lesions later. So there are, right, of course, there's dormant virus sometimes in us, and there are papers for wart virus as well, showing that normal eyebrow hairs, especially of immunosuppressed patients, you can pluck them and you can find wart virus. So there is some degree of maybe colonization. It could definitely be just small incidental, infection of the skin, direct inoculation type of thing. So, I'm not saying that I think wart virus somehow travels internally and creates these small incidental foci. I wouldn't think that either. But see, it makes sense, right? And we did used to wonder, can you touch something and get SARS-CoV-2? And I think the answer is no. And COVID toes is not from some kind of direct inoculation. And that paper helps support that, that all of those cases were PCR negative.